Okay, so our topic today is going to be neurological emergencies. Absolutely, it's a very huge topic, so we're trying to cover as much as possible. I am Mohamed Ali, one of the neurology doctors at Conquest. So in between the session, if you have any questions, anything which is not clear, feel free to ask, stop me, okay? Okay, so neurological emergency, so acute neuromuscular weakness is one of the most common presentation as neurology emergency to casualty and medical department. Acute headache as well is a very frequent presentation, and status epilepticus as well. In this topic, we're not going to cover meningitis, encephalitis, extradural or subdural hemorrhages or spinal injuries. They are more of surgical, neurosurgical topics. Okay, so we'll start with our first case. So, 63-year-old man presented to accident emergency with 2 days history of leg and back pain associated with increasing difficulty in walking. Both this gentleman and his wife had flu-like illness 10 days earlier. So this is a clue here. On examination, he was apyrexial, respiratory rate was 22, no neck stiffness, but both his arms and legs were weak and no reflexes could be elicited. So areflexia or sluggish reflexes. So it varies. It could be absent reflexes, reduced reflexes. Okay. So any thoughts? Any thoughts? Any thoughts? Any thoughts? Where is our future neurologist? Okay. So, what do you want to know from neurology assessment in general? So you need to ask yourself before asking the patient. What do you want to get from the history and examination? Okay. So, it's a neurology lesion, of course. So we need to answer 3 questions. What is the lesion? Where is the lesion? And what is the most likely cause? So from all the history and examination, we are just wanting to answer those 3 questions. What is the lesion, for example? Is it paraplegia? Is it a hemiplegia? Is it only a cranial nerve? Is it extrapyramidal? So this is the question that we need to ask. Okay, so this is the first one, and including, is this signs of upper motor neuron or lower motor neuron? So this is for the first one. What is the lesion? So for example, is it a paraplegia of lower motor neuron or paraplegia of upper motor neuron? Is that clear, guys? Are we on the same boat? Lovely. And where is the lesion? So for example, if we had someone presenting with weakness or paralysis of the lower part of his body, where can we expect the lesion to be? So weak, lower half of the body from umbilicus downward. Limbs, okay. Face, cranial nerves, speech, eyes, swallowing, everything is absolutely fine. So where can we expect the lesion to be? Where about? Yeah? Where about?
Whereabouts?
Yes, in the spinal cord. So we have three parts in our spine. Lumbar, thoracic, and cervical. Okay, so if you have cervical, you remember that the brachial plexus, so he should have something, some weakness of his upper limbs. So if it's only lower limb weakness, then the lesion likely to be thoracic, in the thoracic level. Yeah? And where the spinal cord ends? At which level? The spine. The spine ends at lower border of L1, lumbar disc 1. So lumbar usually is not included in neurology unless it is called equine. Okay? Okay. So this is where And the last question is, what is the most likely cause? So what is the most likely cause? We take it from the hints. Like in this case, the patient and his wife both got upper respiratory tract infection, but now he was apyrexial but a bit breathless. So this is a hint here. We're going to explain this more, okay? Okay, so the second case is an anxious 20-year-old lady presented with mild shortness of breath on exertion, which had come on gradually over several months. So this is gradual deterioration. So the first one is something acute or subacute. This one is gradually deteriorating over months. Okay? Symptoms were intermittent but seemed to worse in the evening. So this is a very big hint here, okay? Her husband said that during these episodes, so it's episodic because so fluctuation over months, she appeared depressed and slurring speech. Any thoughts? Okay, we'll come to it. Don't worry. Okay, so she had been treated for depression in the past and had recently been given lorazepam by her GP. So lorazepam is doing something here. Okay. Also recently started on ciprofloxacin, which is an antibiotic, quinolone, for UTI. On examination, she looked well. Cardiovascular, respiratory, and neurological examination were normal. Pain, nerve, tone, power, coordination, reflexes, sensation was intact. So normal neurology examination. Because earlier we said that this is an episodic, something which is fluctuating. So she might be presenting in a good day. Yeah, for her. Okay. Again, we need to answer the 3 questions. Please, guys, just remember those 3 questions and just keep reminding yourself of them. What is the lesion? Where is the lesion? And what is the most likely cause? Okay? Okay. So the first case, the gentleman who presented with acute weakness 10 days after respiratory tract infection is typical of Guillain-Barré syndrome. We're going to talk about this more. The second case, the anxious lady with fluctuating symptoms, is myasthenia gravis. Okay? So if this lady presented 8 o'clock in the morning, or like a first patient in outpatient clinic at 9 a.m., because she will be sleeping, waking up like 2 hours or something, her acetylcholine will be there, and the examination will be normal. If she presented on the PM clinic, last patient at 4:30, we might find a little bit of signs, ptosis, weakness. Make sense? Okay. And the other hint from the history, if you can remember, that it tends to worse during evening when she's fatigued. Okay? Motor neuron disease. So motor neuron disease is not really an emergency. It could deteriorate very rapidly, but it's not an emergency. Usually patient will be deteriorating over the days without any improvement in between. Okay? Cervical myelopathies or core pathologies, it can present very dramatic in emergency setting. Very dramatic. So if you have something in your upper cervical spine at C4, C5 level, inflammation, whatever is going on, or compression or injury or anything, it can present with paralysis of 4 limbs, sphincteric disturbance, very dramatic. And it depends on the cause. That's why our 3 questions is, what is the lesion, where is the lesion, and what is the cause? So in neurology, like 70% will present with paralysis or weakness. But what will be causing this weakness? So this is the thing that we need to find from the history. So always find the host. Okay? Is that clear? Doing well? Not really. Okay, let's go to B. much more. Not here, right? East Pole, maybe? On fire. Okay, so another rare causes, acute neuropathies, like botulism. You know what is botulism? Botulism? So botulism is the Clostridium botulinum. It's a bacterial infection, and it's usually found in like old or mal-stored tuna or something like this. Usually, it's a toxin, which is exactly the same toxin that we use medically. How we use this bacteria medically? Any thoughts, ladies? Ladies, ladies, come on, come on. You're not there yet, but you never know. Botox. So Botox it gives a little bit of relaxation because it is the nature of this toxin is to relax the skin, to relax the muscles. Okay? So this is one of the medical uses of the toxins. Okay. And Lyme disease, tick bite. Tick bite can cause something called Lyme disease. HIV, of course, can cause neuropathy, vasculitis, sarcoidosis, other poisons, porphyria, heavy metal poisoning, drugs, alcohol, and poliomyelitis. Poliomyelitis is almost eradicated from the world, but you never know. You can find someone who's coming from very remote area having polio. Okay. Okay, so anybody of you knows anything about motor neuron disease? Okay, so it is a mixture of upper motor neuron lesion and lower motor neuron lesion, which we don't usually find in neurology. Usually neurology is either straightforward upper motor neuron or straightforward lower motor neuron. So a mixture of both. Okay, and from the name, it is motor. So there is no abnormality with sensation, no cerebellar signs or ataxia, and no abnormality with eye movements. So it's just motor weakness. So the muscles are weak. Okay, so motor, remember from the name. Okay? Poliomyelitis, as I said, it's almost eradicated. It's a proximal pain. Okay, on hips, upper limbs, usually hips involving lower limbs, and weakness plus or minus bulbar symptoms, so swallowing issues. Okay, cervical cord lesion will present as, at the end, it's gonna be an upper motor neuron lesion, but on certain level. So, for example, if someone is having a lesion on his cervical spine at the level of C7, okay? So anything below C7 will be brisk reflexes, upper motor neuron signs, but only at C7, which is represented where? Which reflex? Triceps, yes, triceps will be lower motor, which is reduced or absent. But otherwise, all reflexes will be exaggerated, spasticity and everything. Okay? Okay, myasthenia gravis, we're going to talk about this, which is characterized by muscle fatigability, dysphagia, dysarthria, and double vision or diplopia. Okay? Okay. So, Guillain-Barré syndrome is an acute inflammatory demyelinating neuropathy, which is IDEP. Anybody know other types of Guillain-Barré syndrome? So this is the classical Guillain-Barré syndrome, which is a subtype called acute inflammatory demyelinating polyradicular neuropathy. There is another types which we can talk about it later. Can you remind me at the end of Guillain-Barré, please? Other type, just quick touches, okay? Okay, so what is Guillain-Barré syndrome? So it's post-infectious, as in our first case, following respiratory tract infection. Okay, so the most common infections, diarrhea and upper respiratory tract. What specific causative agent for diarrhea could be responsible for Guillain-Barré? Any idea? Which bacteria? Absolutely right, and it is worst prognosis. It's one of the worst prognosis. So if you have one of your patients having Guillain-Barré and you think that it was caused by Campylobacter jejuni, you need to be very careful. It usually carries very bad prognosis, okay? Upper respiratory tract infection could be anything, and usually viral. Viral is enough to cause, okay? Okay, so the presentation will be distal paresthesia, back pain are common due to radiculopathy, because from the name is a post-infectious and acute inflammatory demyelinating polyradicular neuropathy. So where is the radicals of the spinal cord? Radicals. So this is the spine. So the nerves originating, the just immediate origin of the nerves is called the radicals. So this is the radicals. So that's why the very early or initial symptom will be severe back pain, because it is just starting from the radicals, okay? And then once it goes forward, weakness, 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 okay? Weakness is often proximal and distal, okay? Unlike other neuropathies, because Guillain-Barré at the end, it's a disease, it's not disease of the spinal cord, it's disease of the radicals. So radicals are considered peripheral nerves, right? It's peripheral nerve, it's not central, okay? So it is considered under the umbrella of peripheral neuropathies. But what makes it a little bit different from other peripheral neuropathies, that the weakness will be, and the symptoms will be proximal and distal at the same time. But in other peripheral neuropathies, the weakness will start from where? The usual pattern of peripheral neuropathy. You know, I'm sure you know. Yes, distal. It's like gloves and stocking. Gloves and stocking distribution. So start from distal. Okay? Okay. Yeah, and symptoms will be in ascending pattern over days or weeks. Depends on how severe is the degree of nerve injury, okay? So, for us as undergraduate, we are only responsible for the classical textbook patients. Okay, so no monkey business, no weird presentation or abnormal presentation. So you just remember the classical one, which is acute inflammatory demyelinating polyneuropathy. So classically, it's bilateral, okay, symmetrical. So the weakness will be starting symmetrically, both sides, okay, and ascending paralysis with bilateral facial weakness. So bilateral 7 cranial palsy, which is quite tricky one to find, because why it's tricky? Because if it's on one side, it will be very easy to get it, like a deviation. But if both sides are weak and symmetrical, the face will be symmetrical. That makes sense? Okay. Okay, and in severe cases, because obviously what makes us to breathe is muscles moving our thoracic cage. Okay, so the muscles will be involved, so there will be some degree of shortness of breath, okay, and some degree of swallowing problem, okay. The progression of this disease is usually over weeks, but can be dramatic. So from initial presentation with the pain, little bit of weakness, to ITU can happen within 48 hours. So it can be very dramatic sometimes, okay?
Yeah, don't worry. Go and get it and then, I said you'd be about 10-ish.
Okay.
Yeah.
And the clinical signs will be frank lower motor neuron signs. Okay.
That's right, darling, I'm just
So can anybody tell me what is the lower motor neuron signs as opposed to upper motor neuron signs? Lower motor.
See you soon. Bye.
So I have something causing lower motor neuron signs, whatever the cause. So I will have weakness. So what about my tone?
Reduced tone.
Yes. And what about my reflexes? Reduced. And as opposed to upper motor neuron, which is
Like increased reflexes, increased tone.
yes. Thank you very much. So ITU, very dramatic. So I had one patient, I diagnosed him with Guillain-Barré syndrome following Campylobacter jejuni, as presumed. He's now paralyzed for, this is his 6 months. He was admitted into hospital for nearly 4 months. He's now in rehabilitation and the weakness can be ongoing. He might improve within a year or something with good rehabilitation. So it is quite dramatic, quite dramatic. So diagnosis. So it's mainly clinical. Someone who's having paralysis following infection, reduced reflexes, typical history of ascending paralysis, frank lower motor neuron signs, bilateral lower motor neuron facial palsy. Okay, let's stop here. Lower motor neuron facial signs.
The motor neuron facial signs.
So we're going to divide the face into two: upper face and lower face. So lower motor neuron, is it going to involve upper and lower part of the face or only one part?
Only one part.
Okay. What do you think? Do you agree with her?
No, I think that's the
Upper and lower part. What do you think?
both.
Both. So it's opposite. So lower, upper and lower. Upper, only lower part. Okay? Good. So guys, the tricky thing about neurology, which is a nice thing, I think, it is clinical. So you don't wait for investigation. If you wait for investigation, simply patient can die. You don't wait for investigation at all. Okay? So, how we can diagnose this? First thing is lumbar puncture, to look for something called cytoalbumin dissociation. What is cytoalbumin dissociation? So it's high protein content of the CSF without any blood cells. So without any like normal white cells count. Okay, so because usually the high protein content is associated with infections. So you will have no evidence of infection on the CSF, but you will have very high protein levels. So this is what we call cytoalbumin. Cyto is from cells, blood cells. Albumin is a protein. Dissociation. Okay. Another important modality of investigation is the nerve conduction study and EMG, which is electromyography. Okay, although nerve conduction study and electrophysiological studies could be negative in early disease. Why? Because the nerve involvement will be just at the beginning, just involving the radicals. And for electrophysiologists to be able to detect a lesion within the nerve, it needs to involve the nerve itself. But the disease is still early and it's just involving the radicals of the spine. Okay? There is, of course, blood antibodies. We can take it here, send it to the lab, and the lab will be sending it to London, and this will take whatever. So we can't wait. We have a patient here. Okay? Another important thing that we need to regularly be doing every day, maybe multiple times during the day, is pulmonary function test, and in particular, force vital capacity. Okay? Why? Because the reason for someone to die from Guillain-Barré is involvement of respiratory muscles. So he will not be able to breathe and simply hypoxia and death. Okay? So you need to be very careful. If you are asked to do one thing for a patient with Guillain-Barré syndrome, do force vital capacity. If it's reduced below certain levels, 1.5 for example, ITU immediately. Okay? So, treatment. IVIGs, what is this thing? Yes, intravenous immune globulins. Now there is a shortage of IVIGs. Read about it, how can we prepare IVIGs? It's very complicated thing to prepare, very complicated. Okay, Plex, what is Plex? Plasma exchange. So plasma exchange or intravenous immunoglobulins and supportive care, which is ITU support. Breathing to prevent aspiration because he will be weak, not able to swallow, even not able to manage his secretions and saliva, so he'll be at risk of aspiration. So this needs particular supportive care. Okay? So now, is it a little bit clear? Little bit? Yeah?
Do you want to talk about the other types?
Aha, thank you very much. So this is the classical type, is bilateral, symmetrical, and ascending. So there is Guillain-Barré which can start with so the limbs will be absolutely fine. It will start with bilateral facial palsy. So this one is a descending part. Okay? So descending part which called Bickerstaff encephalitis. Don't bother yourself with the name. But I just want you to know that there is another subtypes of Guillain-Barré. Okay? Guillain-Barré usually, have we mentioned anything about sensory examination here? No. So the classical Guillain-Barré, which is acute inflammatory either, the sensory presentation will be positive symptoms. When we say positive sensory, is pain. Negative is loss of sensation. That makes sense? So usually the classical Guillain-Barré is positive symptoms, pain and paresthesia. So increased sensation rather than reduced sensation. So there is another subtype of Guillain-Barré that can present with loss of sensation. There is another type of Guillain-Barré which is called pure sensory Guillain-Barré syndrome, so only loss of sensation. Okay? Another type of Guillain-Barré can only present with autonomic features. Only autonomic. So tachycardia, bradycardia, high blood pressure, hypotension. Okay? So this is another variant of Guillain-Barré. Okay? What else? There is another subtype called paraplegic Guillain-Barré. So only paraplegia, as opposed to the classical Guillain-Barré, which will be ascending, involving limbs and lower limb and upper limbs, which is quadriplegia. So there is another type, paraplegic, okay? Another subtype, which is called polyneuritis cranialis. So this is a Guillain-Barré involving cranial nerves only. So third, fourth, and sixth, eye movement, bilateral facial, and involvement of the bulbar cranial nerves. Okay? Just for you to know, but just please always remember the classical one. Okay? Okay, so the second case, what was it? The second case? Anybody can remind me?
20-year-old girl, breathless and exertion, especially in the evenings. The boyfriend noticed something else, which I don't remember.
Depressed, yeah, and slurring speech. Okay, and symptoms tend towards?
In the evening.
Thank you. Okay. So myasthenia gravis is an acquired autoimmune disorder characterized by weakness and fatigability of the muscles. Okay. Which muscles? Skeletal muscles, which is everywhere, bulbar muscles, and ocular muscles. Okay. It's occurring due to failure of NMJ, which is neuromuscular junction. So neuromuscular junction is where the nerve connected with the muscles, and they will be communicating through what? Neurotransmitters. What is it? Yes, thank you. So we call it's the currency exchange currency between the nerves and the muscles. Okay. So, myasthenia is often seen in young ladies, can be acute, progressive, or fluctuating illness like our case. So, what is the pattern of muscle disease in general? Is it proximal or distal? So I have myopathy. Where is the weakness? Is it going to be in my grips or my shoulder?
It's proximal, isn't it?
Yeah. So proximal is a muscle type of presentation, in opposed to peripheral nerve, which will start with weakness distally. Okay. So proximal weakness, dysphagia because of the involvement of the bulbar muscles, diplopia or double vision, and shortness of breath. It can be precipitated by infections, stress, like surgery, for example, someone is having major surgery, or drugs. So what was the precipitating cause in our case? So the lady was prescribed lorazepam, which can make the muscles weak. And what else? Drugs. He was having UTIs treated with what? Ciprofloxacin. Yes. So be very careful when prescribing quinolones, mainly in patients with myasthenia. Okay. Okay, so examination can be normal if you just examine the patient during early hours on a good day, as in case 2, yeah? And we need to test for fatigability. So, explanation like ptosis, extraocular eye movement. So, if you have like a typical case of myasthenia from the history, so you have the notes, you're preparing for your clinics, okay, I have this lady with like this case, so you need to induce muscle fatigability. What can you do? Just ask the patient, can you please blink and count until 60? So she will be okay, nice eyes. So when she 50, 51, 52, 53, 54, 55, 60, after that, because you are exerting her what do you call them? The eyelids, they will be dropping, okay? Another test is to ask the patient to look upward, so an ocular muscle is in action, again for 30 or 60 seconds. At the end of 60 seconds, they will just have diplopia, okay? Another test is ask the patient to keep raising their arms for 1 minute, for example, okay? At the end of 1 minute, they will just be very weak proximally. Okay, that makes sense? So induce fatigability. Induce fatigability. Okay? Dysarthria. So you can be smart trying to elicit two signs on the same time. So blinking and counting until 60. So you will induce fatigability of the bulbar muscle and the eyes at the same time. Okay? Another part of the history is dysphagia and difficulty in swallowing. So dysphagia can be a gastro problem and can be neurology. Generally, what will make you think about neurological cause of dysphagia? So when we are talking about difficulty in swallowing solids and fluid, so in neurology, which one is more difficult?
Liquids.
Yes, thank you, absolutely. Okay, so diagnosis is mainly clinical. Again, clinical. We need to do serum for acetylcholine receptor because it's the main deficient neurotransmitter here. And another thing called anti-MuSK, which is muscle-specific kinase. Okay. Again, electrophysiological studies, mainly electromyography. So we're gonna talk about this. Okay. And again here, because it's weakness of the muscle, we need to be very careful if it's present with emergency and monitor pulmonary function test and forced vital capacity. And as a part of workup, we do CT chest, CT scan of the chest, because myasthenia gravis is associated with something called thymoma, or the thymic cell, responsible of T lymphocyte secretion. So look for thymoma, because if you do thymectomy, this will just improve the prognosis of the disease. Okay? So, anti-acetylcholine receptor is very highly specific and sensitive in generalized disease, because there is another part of myasthenia which is just ocular myasthenia or bulbar myasthenia without involvement of the skeletal muscles. Okay. So electrophysiological studies. Anybody have seen EMG before? So fine needle connected with a wire and connected to a machine. You insert the needle into the muscle and do electrical stimulation. So in normal individual, so repeated stimulation will show the same graph, and in myasthenia gravis, repeated stimulation will show reduced muscle activity. Okay? Treatment again. So neurologists, they talk a lot, but they don't have a lot of options in emergency. So again, IVIGs or plasma exchange. Okay? So IVIGs, intravenous immunoglobulins, and plasma exchange are for emergencies. Okay? in non-emergency, like an outpatient clinic, outpatient, pyridoxine, which is a medication, okay, and steroids. And you need to be very careful because steroids is a treatment and it can cause worsening of the disease initially. So you need to be very careful. You start with a very low dose and you go slow. Okay? You need also to use immune suppressive therapy like azathioprine and MMF, which is mycophenolate mofetil. Okay? So we need to be very careful, as we said earlier, with choosing antibiotics. Generally avoid quinolones. Okay? Cardiovascular medication like beta blockers. Be very careful. And CNS activating medication and benzodiazepines in general, anti-rheumatic medications, and anesthesia. Okay? So you need to tell your patient, you have myasthenia, you need to be very careful. Whenever someone is prescribing any medicine for you, please tell them that you have myasthenia gravis. Okay? Okay. Makes sense? Are we there? No. I think we are running late, so I will be going a little bit quickly, okay? So, acute headaches. So, history is everything. Always look for red flags for secondary cause of headache. So, primary headaches is migraine. Secondary is a headache happening due to something else, which is space-occupying lesion, tumor, bleeding, something like this, okay? So, always ask for systemic signs and symptoms, which can give you a hint. So, for example, if someone is presenting with headache and progressive weight loss. So, this is straightforward. Tumor or cancer with metastasis to the brain. Okay? Always ask for neurological, look for neurological signs and symptoms of raised intracranial pressure. What is the signs and symptoms of raised intracranial pressure? Quickly.
Changing consciousness.
Okay, it's a little bit late. Yes, absolutely right. Yeah. Early things.
Worse if you bend over.
Another, yeah.
Cough.
Yeah, cough. Cough can increase the headache. Yeah. Blurring of vision. What else? Vomiting. And what will happen after vomiting? It will improve the headache. Okay? Very good. Okay. So, in older people, always think about something called giant cell arthritis. We'll talk about it. And glaucoma. Ask about seeing halos around light. Okay? Previous headache had changed. This is a red flag. So, I suffer from migraines for 10 years, but this one is not typical of my migraine. So this is a red flag here, okay? Always ask about triggers, as you said, position, cough, exertion, and intercourse, because there is something called post-coital headache. So post-coital headache is a benign headache, but if someone is presenting with headache after intercourse, it could be post-coital, which is a benign thing, and it could be something dramatic, which is subarachnoid hemorrhage. Okay, so you need to be very careful here. Initial episode, if it's a recurrent thing, how severe, and the onset of the symptom.
What does de novo mean?
De novo means like something ongoing, in another word, okay? Okay. So most diagnoses in neurology are made from history. Again, the 3 questions we need to answer after the assessment. What is the lesion? where is the lesion and what is the most likely cause. So for example, someone is presenting with a sudden onset of headache at the back of my head, worst ever pain, like being hit with a hammer or a thunderclap. So this is, we need to rule out subarachnoid hemorrhage here, okay? Another history, so vision went blurry in one eye, then I got headache on one side of my head, vomited, had to go to bed, happens once a month. Migraine, like ophthalmic migraine, okay? Or IIH, we're going to talk about it. So thunderclap headache, it's a high intensity headache of abrupt onset, sudden onset. It peaks within a minute or less. There is no reliable way, of course, differentiating between primary and secondary thunderclap headache, but we need to be very careful when we hear this word. 1/3 presentation to emergency department with thunderclap headaches are due to potential life-threatening or disabling neurological condition. So if you have 100 patients presenting with thunderclap, 30 of them could be presenting with something sinister. So be very careful. Okay, so important acute secondary headaches. So secondary is headache caused by a secondary cause, which is like subarachnoid hemorrhage, meningoencephalitis, cerebral venous sinus thrombosis, carotid and vertebral artery dissection, or something called reversible vasoconstriction syndrome, temporal arthritis, malignant hypertension or head injury, or something called idiopathic intracranial hypertension, and CSF hypovolemia as well. So CSF's hypovolemia is, we call it a low pressure headache as opposed to idiopathic intracranial hypertension. So like a lady who's delivering with a cesarean section, having epidural anesthesia, okay? So once they are inducing the epidural, a CSF leak happen, this can cause headache. So building up of CSF can cause headache, or leak of CSF can cause headache, which is, we call it low pressure headache. Low pressure headache. Okay? So, sensitivity of CT scan, I think this is very detailed. So, for example, if someone is presenting with a thunderclap headache, simply CT is not enough to rule out subarachnoid hemorrhage. We need to do lumbar puncture. Okay? So, if you suspect subarachnoid hemorrhage, typical history, and CT brain is normal, always proceed for lumbar puncture. So, what is the finding in lumbar puncture? What we are looking for? Something called xanthochromia, which is evidence of a blood within the CSF. So, you just tell the lab, this sample is for xanthochromia. Xanthochromia, okay? If positive CT or xanthochromia in CSF, always discuss first with neurosurgeons. They might need to do some sort of intervention here, okay? Because the causes are divided into two, aneurysmal and non-aneurysmal. It can happen in a normal blood vessel, and it can happen in a blood vessel with an aneurysm. So if it's aneurysmal, they need to do clipping or something for this aneurysm, okay? So for example, this is a subarachnoid hemorrhage. So this is the bleed, very fair bleed. It looks like normal, but if you can see a little bit of a rim here, so this is likely the aneurysm here, okay, which is ruptured. Okay, so we need immediate neurosurgical advice. Rising blood pressure and reducing pulse rate is an indication of raising intracranial pressure. Fixed dilated pupil indicate a herniation, downward herniation. So medically, we need to start a medication called nimodipine. What is nimodipine? Yes, calcium channel blocker. So this medication is very important. It's not a treatment, but there is a very frequent complication. So once subarachnoid hemorrhage happens, the brain will try to reduce the bleeding, cause vasoconstriction, and this will cause ischemia. Okay, so we give nimodipine to prevent the cerebral vasospasm. Okay, mannitol, intubation, ventilation, and other supportive care. So if the patient was doing well and all of a sudden started to deteriorate, you need to think about communicating hydrocephalus. So the bleeding will alter the CSF flow because the blood can clot, yeah? So this will alter the CSF flow and will cause hydrocephalus, okay? Okay. I need someone, a clinician, future neurologist, to come forward. Can you see it from here? Because we need to look into something. So, which eye is abnormal? Come,
Sorry?
come have a look.
Oh, I don't know.
Just, it's going to be something. So can you, yeah, look at the pupils. Which one looks normal and which one looks abnormal? If you can't see, come closer.
Is the left one abnormal?
So this is the right and this is the left. So which one is abnormal? Look at your colleague. Look at her eyes. Look at her eyes. So look at her pupils. Looks okay, reasonable size. Yeah. Yeah, she's normal. She's okay. Yeah. So this one is dilated. So this one looks abnormal. Okay. So this is usually associated with the third nerve palsy. Third nerve palsy. Okay. So if you have someone presenting with a third nerve palsy preceded by a headache, we need to think about aneurysmal rupture, which is a very sinister problem, usually caused by posterior communicating artery aneurysm rupture. So can we remember the circle of Willis? Posterior communicating artery, very small artery can cause this sinister problem, okay? Yeah, so this is the posterior communicating artery aneurysm, okay? We are nearly there.
Okay.
Thank you. So another case, a 25-year-old lady seen in the emergency department, daily headache for the last 6 weeks, loss of vision momentarily when bends downward, and some visual obscuration with any vasalva or bending forward. Any thoughts? Okay, this headache again worse in the morning, and recently prescribed oral contraceptive, combined oral contraceptive. Her weight had been fluctuating. Recently put on some weights and her BMI is 33. So what do you think? So this is a typical case of idiopathic intracranial hypertension. Okay, headache, visual obscuration, vomiting. Okay, risk factors could be like weight gain or oral contraceptives, especially combined oral contraceptives. Okay. So examination, there will be bilateral papilledema, reduce visual acuity and visual fields, and can present with bilateral 6-nerve palsy. Okay? I think she's trying to say stop, right? No. We're not. Are we stopping? More 5 minutes. Is that right? Okay. What else do you have after this session?
Another lecture.
Another lecture. Just the last case. So it's a 70-year-old man with 2 weeks history of constant pain on the left temple, tender when he's combing his hair, pain after chewing and speaking. Fundoscopic examination showed swelling, optic disc or pain optic disc if delayed presentation. So be very careful here. You can save this gentleman very easily. On examination, let's try to feel the temporal artery. Okay, it will be feeling hard, tender, and non-pulsating. Simple test: do ESR, high ESR, immediately start steroid. This is giant cell arthritis. You can save this gentleman vision. Okay. Migraines and clusters. Okay, so I think we need to stop here, and hopefully we'll be able to continue next time. Okay? I hope this makes sense to you. Okay? Thank you very much.
Would it be possible for you to send me a copy of the presentation?
Absolutely.